She wakes at 6:15, the same as always. There is a vague heaviness in her jaw, the kind she might describe as dental if anyone asked. Her left shoulder feels stiff in a way that is not quite like her usual morning stiffness. She gets up anyway, makes coffee, decides she will mention it to someone if it is still there tomorrow. It is not still there tomorrow. She is in the emergency room by 9 that morning. The jaw, the shoulder. She had not known what they meant. The symptoms of a heart attack in adults over 60, particularly in women, are some of the most consistently misread, delayed, or dismissed signals in all of medicine. Not because people are careless, because the symptoms often do not match what most people have been taught a heart attack looks like. The chest clutching, left arm radiating, unmistakable presentation that appears in television dramas is one presentation. It is not the only one, and it is not even the most common one in people over 60. What fills the gap between what people know to watch for and what the body actually produces is a conversation that does not happen often enough, quickly enough, or with enough specific detail to be genuinely useful. My name is Dr. Evan Noris. I'm a cardiologist with 22 years of clinical experience, with a particular focus on cardiac event recognition and emergency response in adults over 60. What motivated this video is the number of patients I have treated whose outcomes would have been meaningfully different if they had recognized what they were experiencing 30 minutes sooner. After 60, the presentation of myocardial ischemia, reduced blood flow to the heart muscle, changes in ways that are physiologically well understood, but clinically underappreciated. The heart muscle, after decades of work, may have developed collateral circulation around partially blocked arteries, which can blunt the sharpness of chest pain even during a significant ischemic event. The nervous system, which has been quietly altered by decades of blood pressure variation, and in many people by the early peripheral neuropathy of prediabetes or diabetes, transmits pain signals less predictably. The hormonal environment differs significantly between men and women, which is why women over 60 are substantially more likely to present with atypical symptoms: jaw pain, nausea, profound fatigue, breathlessness without chest pain, that bear little resemblance to the textbook presentation. Think of the warning system as a complex electrical circuit that has been modified by decades of use. The signal still fires, but it may arrive at a different terminal than the one that was wired at 40. According to the American Heart Association, women are more likely than men to experience atypical heart attack symptoms, and delayed treatment due to symptom misattribution contributes measurably to worse outcomes in women over 60. Recognizing what the circuit produces, wherever the signal arrives, is what the next few minutes are about. Before I walk through each warning sign, I want to ask you something. Have you ever experienced a symptom that concerned you briefly, but that you decided to wait on before reporting? Just type yes or no in the comments. Most people have. Understanding how common that hesitation is helps me understand the conversation this community needs. The first warning sign I want to address is unexplained jaw pain or tooth pain, particularly pain in the lower jaw, that arrives in the morning without any dental history or preceding dental procedure to explain it. Jaw pain is a symptom of cardiac ischemia, occurs because the nerve pathways that carry pain signals from the heart travel through the same spinal segments as the nerves that supply the jaw, lower teeth, and throat. When the heart muscle is deprived of oxygen, the pain signal follows these shared pathways and is experienced in the jaw rather than, or in addition to, the chest. This referred pain mechanism is well established in the cardiological literature and is more likely to occur in women and in people with diabetes, whose modified peripheral nervous systems change how cardiac pain is transmitted. After 60, dental complaints are common, and the temptation to attribute new jaw discomfort to a tooth, to temporomandibular joint changes, or simply to sleeping on the wrong side, is understandable and often correct. What distinguishes a cardiac jaw pain is its character. It typically does not localize to a specific tooth. It comes on at rest or with mild exertion, rather than being provoked by biting. And it may be accompanied by breathlessness, sweating, or a vague sense that something is not right. A woman named Lenora, a former botanical illustrator who had spent 40 years doing close, precise work with exceptional attention to physical detail, described jaw discomfort that had woken her on 2 mornings in the same week. She attributed it to stress and a new pillow. Her dentist, whom she called on the third day, found nothing. When her cardiologist, whom she saw 2 days later at her dentist's insistence, evaluated her, she was found to have significant left anterior descending artery disease. The practical fix: new jaw or lower tooth discomfort in the morning without a dental explanation, especially if associated with any other symptom, breathlessness, sweating, shoulder heaviness, should be evaluated as a potential cardiac symptom same day, not in a few days. The second warning sign is unusual and disproportionate fatigue, not the tiredness that comes from a poor night's sleep, but a profound heaviness that makes simple morning tasks feel unexpectedly effortful. This symptom is one of the most commonly reported in the days leading up to a heart attack in women over 60, and one of the most consistently attributed to other causes: poor sleep, stress, a virus, general aging. The physiological basis is this: when the heart muscle is receiving inadequate blood flow, it must work harder to maintain output. That increased cardiac workload diverts oxygen and metabolic resources that would otherwise be available to the body's other systems. The result is a global sense of depletion, not muscle soreness, not sleepiness exactly, but a functional heaviness that sits beneath everything. Research published in Circulation documented that among women who had experienced a heart attack, a significant majority reported unusual fatigue in the weeks preceding the event, making it one of the most sensitive prodromal symptoms in this population. A man named Stellan, a former commercial fisherman who had spent his life in physically demanding conditions and whose baseline tolerance for fatigue was extraordinarily high, came to see me after 3 mornings of waking with what he described as feeling like he had already worked a full shift before getting out of bed. He had no chest pain. He had no other obvious symptoms. His clinical intuition told him something was different, and that intuition was correct. Urgent evaluation revealed significant coronary artery disease requiring intervention. The practical fix: if you experience fatigue that is qualitatively different from your normal tiredness, heavier, more pervasive, arriving in the morning, and it persists for more than 1 or 2 days, call your doctor the same day rather than waiting for it to resolve on its own. The third warning sign is breathlessness on minimal exertion. Specifically, breathlessness that is new or that has worsened in the recent weeks, and that occurs with activities that previously caused no difficulty. Walking from the bedroom to the kitchen, climbing 4 steps to the landing, getting dressed. After 60, mild breathlessness is easy to normalize. The reasoning follows naturally that lungs age, fitness decreases, bodies slow. But breathlessness that has changed in character or threshold in recent weeks is a different signal. When the heart muscle is ischemic, its pumping efficiency drops. Fluid backs up into the pulmonary circulation. The lungs become less efficient at gas exchange, producing breathlessness at lower and lower levels of effort. This can precede a definitive cardiac event by days or weeks, making it one of the most actionable prodromal warnings. Actionable precisely because it appears early enough for intervention, if someone recognizes it. A woman named Perpetua, a former botanical garden curator who had maintained an active working life well into her mid-60s, and who had noticed with some bewilderment that she needed to pause at the top of her front steps, came to see me describing the change as modest and gradual. She was embarrassed to mention it, she said, because it seemed like such a small thing. It was not a small thing. An echocardiogram and subsequent workup revealed significantly reduced left ventricular function that had been developing for months. The practical fix: if you are newly breathless doing something that has always been easy, and the breathlessness has appeared or worsened in recent weeks, report it to your doctor without waiting for a scheduled appointment. New breathlessness on minimal exertion in someone over 60 is a symptom that warrants same-week evaluation at minimum. If you are still with me and finding this important, type the word "aware" in the comments right now. Staying through this conversation could genuinely matter. The fourth warning sign is nausea or indigestion that arrives in the morning without an obvious dietary cause, particularly when it is accompanied by any sense of chest discomfort, sweating, or general unease. The heart sits directly above the upper digestive system, and when the inferior wall of the heart, the bottom portion, is ischemic, the pain and discomfort is frequently experienced as stomach upset, heartburn, or nausea rather than chest pain. This is one of the most dangerous misattributions in cardiology, because it leads people to reach for an antacid rather than a phone. After 60, gastrointestinal complaints are common enough that new nausea rarely triggers alarm on its own. The distinguishing feature is the context. Nausea that arrives at rest, particularly in the morning, without recent dietary provocation, and that is accompanied by any other symptom: sweating, jaw discomfort, shoulder heaviness, unusual fatigue, is a different clinical picture from nausea after a rich meal the night before. A man named Bernardo, a former harbor customs officer with an exceptionally calm demeanor, who had never been prone to alarm about his health, came to see me after his wife described watching him sit very still at the kitchen table one morning, looking pale, saying he felt nauseous and a little off. He had no chest pain. He thought he had eaten something disagreeable. His wife insisted they go to the emergency room. He had an inferior wall myocardial infarction in progress. His wife's insistence saved significant heart muscle, and very likely, his life. The practical fix: nausea arriving at rest in the morning, especially alongside any other atypical symptom, should not be attributed to diet until cardiac causes have been excluded. If there is any accompanying symptom, however mild, call emergency services rather than waiting. The fifth warning sign is one that people almost never associate with the heart, and that is a sudden and profound sense of dread or impending doom that arrives in the morning without a corresponding life event to explain it. This is a documented and physiologically understood prodromal symptom of serious cardiac events. When the heart muscle is severely ischemic, the body's sympathetic nervous system activates globally and intensely. Adrenaline floods the circulation. The brain interprets this global alarm activation as a threat of existential magnitude, because it is one. The result is a subjective experience of profound fear or dread that patients often describe as unlike anything they have felt before. Not anxiety, not worry, but a certainty that something is badly wrong. This symptom is consistently underreported because people feel embarrassed by it, attribute it to a nightmare, or dismiss it as a psychological event. In clinical practice, when a patient over 60 describes waking with an overwhelming sense that something is terribly wrong, particularly alongside any physical symptom, however mild, that description should be taken with the same seriousness as chest pain. A woman named Rhiannon, a former marine cartographer of extraordinary composure, who had never described herself as anxious or prone to fear, came into the emergency department one morning brought by her daughter, whom she had called at 5 in the morning to say she did not know why, but she felt certain something was very wrong. She had no chest pain, no jaw discomfort, no breathlessness she had noticed. The troponin blood test confirmed an acute myocardial infarction. Her instinct, unnamed and unexplained, was the only warning her body produced loudly enough to act on. The practical fix: if you wake with a sense of profound, unfamiliar dread, particularly if any physical symptom accompanies it, however subtle, do not dismiss it as psychological. Call someone. Go to the emergency room. The sense that something is wrong may be the most accurate diagnostic instrument you have. Here is what I want you to do with this information. Write down the 5 things I have described: jaw or tooth discomfort without dental cause, unusual and disproportionate fatigue, new breathlessness on minimal exertion, morning nausea without dietary explanation, and a profound sense of impending dread. Put that list somewhere you and the people around you can find it, and share what you have just watched with someone you care about: a spouse, an adult child, a friend. Because in a cardiac event, the people around you are often the ones who make the call that matters. If you experience any of these symptoms in the morning, and they persist for more than a few minutes, do not take an antacid. Do not lie down and wait. Do not tell yourself it will pass. Call emergency services. Time is heart muscle, and the window for meaningful intervention closes quickly. Everything I have shared here is educational information, meant to support a conversation with your own physician, not to replace one. Your specific cardiac history, your medications, and your individual risk profile all shape how these symptoms should be interpreted for you personally. Please bring this conversation to your doctor. They can help you understand your individual warning pattern and create a response plan before you ever need it. And if understanding what your heart may be signaling before a serious event has raised questions about the habits and conditions that gradually build toward that risk, the next topic I want to explore with you is what the most current research identifies as the silent contributors to coronary artery disease in adults over 60, and what can still be done about them.